Hey, good afternoon, everyone. Thanks for joining us for our InfoDive webinar on E&M coding today. I'm Karen Joba from the InfoDive support team, and I'll be doing the presenting today. If you have any questions during the webinar, please enter them in the chat, and we'll answer all those questions at the end of the presentation. We do have a key report packet for today's webinar, and you can find that in your client document library in the portal under the support tab. If you have any questions specific to your own data after you review it, please call our toll-free number that's also found under the support tab, or you can send an email to providerclientservices@intrinsic.com and we will be happy to help you. And then when you exit the webinar today, if you would please rate it on a scale of 5 down to 1. We also have a couple of just quick questions for you today as well that we would really appreciate you answering. So let's just go ahead and get started with our normal disclaimer that any information presented today is solely for educational purposes and not intended to replace your internal resources or legal counsel. We present information to the best of our ability. We always use blinded data in anything we share with you, and we don't promote or endorse any specific products that may be present in today's presentation. A couple of just housekeeping notes before we get started. We report 2 plus the current year of data in the portal, but right now we have all of 2023, 2024, and 2025, and then January of 2026 if you've already had your refresh this month. And that's going to allow you to see 3 full years of data, which is great for trending. We will be dropping that 2023 data with the March refreshes. So if you have specific or custom reports that you like that include 3 full years, you're going to want to run those now before we remove that 2023 data. If you want to keep your 2023 data a little bit longer, just contact us in support and let us know, and we'll make arrangements to have that happen for you. And you'll always have your key report packet that's going to have data. But again, if you have like a custom report or something that you're running every month, you're going to want to run those reports before we drop that data next month in March. Also, Congress passed H.R. Bill 7148. That was the Consolidations Appropriation Act, and that kept the GPCI work floor at 1.0 through January 1st of 2027. They also extended the telehealth policies through December 31st of 2027. So that was like a 2-year thing, which is great. And both of those actions really are going to help out the rural practices. Now, I've given you a link to the actual bill where you can find this information. And if you want to see it, it's in section 6208 and 6209 in that bill. Some coding updates. There's always changes to CPT coding, and 2026 is certainly no different. This year included 418 changes. There were 288 new codes, 46 revised codes, and 84 deleted codes. We reviewed some of those coding changes when we did the final rule in our last webinar at the end of the year, but today we're just going to focus on evaluation and management coding. And so the big changes in that category were in remote monitoring codes. So if you build those remote monitoring codes, you're going to want to go and really review what all those changes are. Now, I've given you the link to the AAPC, that's the American Academy of Professional Coders, to that website, and that's a great resource where you can really find details on all of those changes. So let's talk about coding audits. Do we have to do a coding audit? And the short answer is yes. How frequently you perform the audit is up for discussion, but in general, all the agencies like the AMA, the MGMA, the AAPC, they all say you should perform a coding audit at a minimum of once a year. So I pulled these audit goals off of the MGMA website, and I think this is a good resource because it's a pretty comprehensive list of what you're going to try to accomplish with your audit. You're going to want to identify errors in provider documentation, use of incorrect medical codes, such as any deleted or modified codes. You're going to determine under or overcoding, checking modifier usages, etc. Now, you can outsource your audits, of course, but if you're going to do it in-house, you really want to know what's changed since last year. So in 2026, when it comes to the documentation, the focus continues to be on the medical decision making, just as it was in 2025. The value, they're saying the value is on the cognitive work versus the documentation volume. So you no longer have to do all those multiple system reviews and a complete physical exam just to justify a higher level code. So this chart does give you some time guidelines for visits to help decide the level of coding. And just remember, the time should be the total time of service on that date. So you want to include the time it took to review any prior records, any imaging and lab results, any peer discussions that you might have had about a patient. All of those things take up your time. So, don't sell yourself short. And then don't forget about the add-on codes of G2211 and G2212. G2211 is for visit complexity that's associated with clinical conditions, and it can be added to any level visit. So you might be having an established patient visit that's a level 4 or even a level 3. You can still add that G2211 because the purpose is to compensate providers for that ongoing, active, proactive, and relationship care management that just goes beyond that first acute care appointment. Now, these providers are going to be the continuing focal point for all the needed services. So those primary care practitioners, they should be really looking at that code. Or if you are providing ongoing care for a single serious or complex condition, so like oncology, any of those diagnoses, you can also bill that code. And the national rate of reimbursement for G2211 is $17.37, and that's non-facility. So, that's not bad. If you're doing all that work, you should bill that and get paid for it. Now, the G2212, that's used for when you go over like that 75-minute mark for a new patient, or that 55-minute mark for an established patient. And this code is designed to compensate the provider for all that extra time. And again, we aren't talking about face-to-face time, but the time that it takes to review all the records, see the patient, have peer conversations, formulate the diagnosis and the plan, and that code reimburses at $34.07 for non-facility. And again, that's the national rate. So 2 good codes to really look at if you aren't doing it yet. So how do you justify your coding? According to the AMA, you want to be very clear on the problems that are addressed and any data reviewed, including the amount of time that it takes to review that data. So again, those previous medical records, test results, labs, consultation, peer, all of that counts. You also want to outline the risk and the possible complications of medication and potential procedures. That's how you're going to show how you came up with that medical decision making, right? The complexity of it. So the focus is really on how and why you make your treatment plans. It's not on checking a bunch of boxes in a template. And that, in theory, should reduce the whole documentation burden. I wanted to include this slide because this slide shows you how the reimbursements have changed with the changes in the RVU components this year. Now, the E&M codes were exempt from the efficiency adjustment, but most of those codes saw an increase in the total RVU due to the fact that CMS changed their practice expense methodology. So now they allocate more money to non-facility versus facility-based services. So you could see here that that really resulted in most office visit codes seeing an increase of at least 7% based on the national rates. And that's when you combined those RVU increases with that conversion factor increase. So how can InfoDive help? Well, we don't have access to your EMR notes, but we do have many reports to help you identify patterns in your practice and also to show how other providers are billing in your specialty. So we're going to focus on these reports today when we get over to the portal. And I've included slides of the reports that we're going to cover on these next couple of slides. I'm not going to go through them now because I just want to go straight over into the portal, but we always include these slides just so you have a portal path. So if you're looking at a webinar and you want to look at the slide deck and say, okay, is this something that could help me? You'll have that portal path right away. And then just as a reminder, all of our webinars are recorded and those links can be found under the support tab. All right, we're going to go over to the portal now. And we are going to be in a blinded urology account. And so we're going to focus under this coding tab. And so one of the first steps to doing an audit is identifying, like who's going to be a good person to audit, and is there any outlier? Do we have any cluster coders? So instead of starting with this top report, I'm going to start with this provider comparison report. Now you're going to see we have a graph and a report here. If your practice has a boatload of providers, you're not going to want to use this report because you could see that this would get really ugly. But you would just use the report part of it. But this practice is not too bad. And so this just kind of gives you like a color-coded idea to let you see how often they're choosing these different codes. And you can see we have the filters. And so we're looking at office visits for established patients. We could also look at office visits for new patients. I'm going to come over to the report just because I feel like the report's just a little bit easier to read. And you'll see here how I have it for all values. I could isolate, certainly if I have a lot of providers, I could isolate one, either new or established, but for our purposes, we can leave it right here. And so what this is going to show you is how many service lines for E&M visits that each provider billed, and then how did it break down? Did they bill? What level did they bill? So if you just go across the top here, you could see Sarah Beasley out of 1,764 E&M codes that she billed, 146 times they were a level 3, 1,385 times they were a level 4, 200 times they were a level 5. And if I look at that percentage, 78.5% of the time she's billing a level 4, and 11.3% of the time she's billing a level 5. And these are on the established patient codes, right? If I go down through here and I could see, I can just start to look for a trend, right? So here, Terry Carver on his established patients, he's billing at level 3 86% of the time. So a little bit higher than what she's doing, a little bit higher than everybody else. Now this provider 100%, but they only have 6 service lines, so we're not going to focus too much on that. But this kind of gives you an idea of how your providers are comparing to one another in coding. And then if I come down to the new patients, I can see again, Sarah's billing that level 3 new patient 43% of the time, level 4 50% of the time. And I can come down through here and I can look, but look, Terry Carver, he bills a level 4 new patient visit 98.2% of the time. And that would seem to be a little bit of a cluster coding. Now, if he's got the documentation to prove all that, then, no problem at all. No problem at all. But he might be someone that I would say, you know what, this might be a good person for me to go and start my chart audit with to see what I can identify here. Now, once you've had this and you've identified it, you might want to go and look and say, well, how does this impact our reimbursement? So that's where this report comes into play. That is this coding levels with benchmark report. I love this report. Some people, I think this report is super helpful, and it's going to default, and I'm going to come over here and I'm going to pick physician. It's just going to default to that APP, and then you got to pick your specialty, right? And I'm going to pick urology. And let's start with Sarah Beasley. Okay, so what this report is showing me is that on her new patients, as a new patient, she had 559, and we're looking at the recent 12 months, you guys, when we're looking at data. So here she had a level 3, that 43% of the time, a level 4, 50% of the time. The provider group, if you have multiple provider groups, and so maybe you are a multi-specialty practice and you separate your people out by group, then the provider group would tell you, here's what the provider bills, here's what his group bills, what the percentages of how his group bills. And then you would have the whole practice and how the practice bills. Now, there's no provider group here, so these numbers are the same. But then this next column is going to be the InfoDive community. So we're saying that Sarah bills a level 4 50% of the time. All of the urologists in the InfoDive community, they bill a level 4 68% of the time. And then CMS puts out these public use files that they put out, and we get them every 2 years. So in 2023, all of the urologists that were billing CMS, they billed a level 4 72% of the time. And if Sarah coded more like CMS, then that would have resulted in an additional $5,816 of revenue for her. And if we look at the established patients, she would have seen a little bit of a different result though, right? Because she's coding that level 4 79% of the time on her follow-up visits, where if you come over and you look across the board, her practice is coding at 55% of the time. InfoDive community is coding a level 4 58% of the time, and CMS is coding it 53% of the time. And you could see that if she coded more like CMS, so what we're saying is like, okay, of her 1,764 patients, if 53% of those were coded as a level 4 and 40% as a level 3, et cetera here, that would have resulted in a difference of a negative $33,000 for her established patients. Let's come up and let's just take a look at Terry Carver, because he was the one who's coding 98% on his new patients. So if you take a look at his money and how his looks out, if he would have billed like CMS does on his new patients, and he didn't have quite as many new patient visits, he would have seen a decrease of $2,000, $2,136. But if he would have coded the way they did on their established patient visits, and not coded every 87% as a level 3, he would have seen an increase of $35,000, $35,880. So again, if your documentation supports that level 4, then by all means, but what this report helps you see is, okay, what percentage of those CMS patients are out there? And so if they see a patient that's coding a level 4 98% of the time, they might be a target for that audit, right? So that's why you want to just keep in mind. But again, as long as you are you can document what you're doing, or maybe he has a really higher maybe his diagnoses are justifying that. And one of the ways that we could see what their diagnoses are is under this report here. And this is going to be your coding levels by primary diagnosis. And again, we got to select everything in our filters up here. So I'm going to just stick to new patients, and I'm going to stick to urology. I'm going to select Terry Carver because I want to see what kind of patients is he seeing. So I'm going to select Terry Carver in my filters. Again, I'm looking at the recent 12 months, right? I'm just looking at the recent 12 months. And so here I'm going to see his diagnosis. His top diagnosis is going to be that elevated PSA. And 100% of the time he's coding a level 4 visit on those new patients, where in InfoDive, the practice is all the urologists in InfoDive are coding that diagnosis as a level 4 79.7% of the time. His second percentage is BPH. He's coding a level 4 95% of the time. So if I wanted to see, well, how does that compare with the practice? Then I can just come back up here and I can select all of my providers. So if I come back up here, and if I just come right in here, I can select, and it'll clear and it'll say all values. And now I could see, okay, so BPH, 91% of the time, all providers in the whole practice are coding a level 4. The InfoDive community, it's 83% of the time. On that R97, that elevated PSA, the practice is doing it 91.7% of the time. InfoDive is doing it 79.7% of the time. And so you can just continue to evaluate these reports and look at the diagnoses. But let's say you say, okay, well, you know what? I'm ready to do an audit, and I'm going to pick out a couple of providers, and I'm just going to go and take a look. The easy way to do that is under this report here. I can get a detail. So I can come up, I can get a claim detail with, now obviously we really want to take a look at the time frame, because nobody's going to want to look at 3,000, 3,707 charts. So I could come up here and I could say, you know what, I'm going to just look at, that R97.20, because I want to just be able to compare the notes of how people are coding. Now you'll notice sometime on the new system, I just want to kind of point out that sometimes when you check the box, it takes a minute for it to register that it's checked. And so if you're expecting it to happen instantly, I know for me, like I'll check it, then I'll uncheck it because I think I didn't check it because I don't see it. So you have to kind of like take your finger off the mouse a little bit with our updated system now, so that it actually holds that spot for you. And then I'm going to come over and I'm just going to pick a particular month. I'm going to pick October. And again, so you kind of saw that little delay. And here's another thing that we see a lot, right? you think you might be selecting just 1 month, you also want to always make sure you're coming over here and you're taking off that recent 12-month figure. I see that happen quite a bit. Okay, so now I could see, and I've got both established and new. I just want to look at new. So I'm going to come up under this E&M category and I'm going to say, just give me my new patients. All right, so now I have a much more manageable group of charts, right? So I could take this list out into Excel and I could hand it to my whoever's doing the audit, whether that's an outside resource or if that's a certified coder that you have in your practice, however you wanted to do it. And I could say, okay, I want you to go take a look at these charts with this particular diagnosis. And I just want to make sure that everybody is documenting to the level that they're supposed to be documenting. And, you know, right off the bat, you can see it's a little interesting that, like, to me anyway, this is interesting that this provider here, Leroy Griffin, sometimes he bills a level 3, sometimes he bills a level 4, but there's always just this one diagnosis code. So I'd want to see, like, what's the difference in his notes, right? That he billed a level 3 this time, but these other times he billed a level 4, and there was just the same diagnosis. But this is just a great way. You've got their data service, you've got the patient ID, you've got the diagnosis, and you can go out and you can just compare. And you could even do this, so you could select your payer up here. You could do this for just one specific payer. You could do this for you know, you could do it just for Medicare, you could do it just for, you know, whichever payer you wanted to do, whatever financial class you wanted to do. So you could say, okay, I've got 50 charts here. I'm going to go look and see if I want to take out, I'm going to take that one out just by clicking on it and backspacing. And I'm going to go look and pull up another diagnosis. I'm going to pull up that BPH. And I've got 143 charts here. So, you know, you get to decide how many charts you think is reasonable for a chart audit. And I suppose you could go out there and look and see. I didn't go and look and see what the average number of charts are that people audit, but you could certainly go take a look at that. But if I say I audited 143 plus, you know, another 50, I audited 200 charts. That's, to me, in my mind, I would think that's a pretty good audit, right? For you to be able to get a good idea of what's happening in your practice. Another way to keep an eye on what's happening in your practice is under these trend reports, under this coding trends. Now, this report is going to just let you know how you're trending over a period of time, right? So I'm going to come up and I'm going to select new patients. And I will tell you that I've seen people, we have one practice in particular that's really been focused on their coding and changing how they code and documentation, and so they've really used these reports, and this trending report is super helpful, right? Because then they can see, okay, how, you know, have I been documenting better and have I been able to bill a higher level code? Because the goal is obviously if you can document all the work that you're doing and that's resulting in a higher level code, that's going to be a higher level of reimbursement for you. So this trending report lets them really see if they, you know, are they accomplishing all of that. So they went from 23%, I mean, not this particular practice, but 23% for a level 3 down to 18%, and then build a few more level 5s. So this really lets you do that. And you could pick just one particular provider up here in your filter, or these are flippable reports. So you could also just flip this, and I can just left click here and, like, I want to just see by specialty, right? Maybe I just want to see by specialty. And I did put this in your key report packet today just because I think it's an interesting report to see how they code by specialty. So you could come through here and you could just see how the trend is looking. And again, because it's by service quarter, but you could change it to something else if you wanted. If you wanted service month or whatever, you could flip this report to see that as well. But this really just lets you see how you're trending, if you've been really making a push towards additional documentation and being able to code a little more, you know, if you want to, you know, try to increase your documentation to get those revenues up a little bit. E&M revenues make up a big chunk of most of our practices, so it's, you know, it's definitely worth your while to do a chart audit and see where you can make those improvements. So I have one more report I want to show you. And that is actually a new patient report, and that is found under episodes of care. And this is a multiple new patient audit report. So you'll remember that you can bill a new patient code every 3 years. So this report lets you, and this particular practice has done really well, right? They've in the recent 12 months, but we could select this filter for for any particular time. Like we could say, give me all of these, right? By just clicking on that and see how well they are. Then it gets a little bit bigger. So what this report lets you know is if you build a new patient code too frequently, and if you got paid on it, then you could probably expect for that money to be recouped back, right? Now, if it's Medicare, you could certainly sort on these payers, and if it's Medicare and you've built that new patient code too frequently and you got paid on it because Medicare didn't catch it, Medicare expects you to go back and reimburse them that money. If it's a private insurance, they're going to recoup it anyway, and they do a better job. They do a good job at taking back their money. So I'd let them find that. If it were me, I would let them find that. Now, there are times where a new patient code is billed twice in the same practice because there's multiple specialties. And so when you have that different taxonomy, then like if you have an oncologist and a urologist in your practice and they both see a patient for the first time, they should both be allowed to bill that new patient code. But if they're looking at the same specialty, so for example here, even just this first one, even though Gilberto Baker saw this new patient in March of 2023, when Jared Callahan came in and saw this patient in February of 2024, and maybe they got scheduled as a new patient, but it should not have been billed as a new patient because it's not been 3 years. Okay, so this is how I would use that report. All right, so those are all of the reports that I have to review with you guys today. I know we have a couple of minutes left. And I do see that we had a question. Looks like someone wanted to know if G2211 can be billed at the same time as G2212. And the answer to that question is yes, because they're different. They mean different things. One other thing I will tell you about G2211 is that for a while they said that it could not be billed with the modifier 25. And I did learn when I was doing a little bit of research is that the G2211 can be billed with the modifier 25 so if you have an E&M code with the modifier 25 and you want to build a G2211, you can do that. It's just specific to what those codes are. So what I saw is that if you're billing it with a well visit, or if you're billing the 25 modifier because you had a vaccination code, then you can certainly still bill that G2211. So I hope this helps. If you guys have any other questions, please go ahead. You can go ahead and submit them here, and we'll certainly get those answered for you. If you wouldn't mind, please finishing. If you wouldn't mind doing that survey at the end of the webinar today, we really appreciate any feedback that we get from you guys. We'd love to have ideas for new topics, anything that you would like to see covered in the next webinar. But other than that, that's really all I have for you today. So I hope you have a great day, and we'll look forward to seeing you for our March webinar next month. We'll be covering benchmarks. So thanks, everyone. Have a great rest of your day.